I think we've met someplace along the way. Your work has certainly influenced me.
And yours, mine.
I'm a recovering family doc, working in the interface of public health and family medicine, though mostly now writing fiction, and doing a little bit of public health primary care in the city of Central Falls, Rhode Island.
John Zubialdi took me to a session that you had on generalism some years ago. Or maybe you didn't host it, but you were there, and you talked about how much it costs to fund primary care. I think it was $14 a month or something like that.
Yeah, you remember that.
I do.
I ran those numbers first in 1996, and fell into the notion that in 1996 it cost $106 per year to supply primary care per person per year, and sort of that pointed out that number was that small percentage of the entire healthcare spend. The health insurance companies get 20%, and as we now know, primary care gets 5%. I've never met a health insurance company executive who takes a patient's phone call at 3 o'clock in the morning.
No compassion there. Okay, Pat Tokars.
Hi, folks. Jim, we've had sort of parallel careers. We both signed up for family medicine out of idealism. As a resident, I was able to get the AMA to write a book called Beyond Survival, which was an attempt to get all residency programs to help prevent physician burnout, physician impairment through teaching values clarification and life planning to residents as a skill, as well as medical students. Since then, I've been trying to do that for my patients. My main question when I talk with patients is, how healthy do you want to be? Letting them know that it's really up to them to decide what they're willing to do and how important health is to them, so that we go first, as they say in the National Guard. We go towards the people that are coming towards us to help them, because they're the ones that are most motivated. So I'm very interested in what you have to say, and envious of your retiring to North Carolina. That's a beautiful place. I grew up in Tennessee, so I spent a lot of time in the Asheville area and the Triangle area. So I'm looking forward to learning how retirement is going for you. Thanks for joining us.
I probably would have settled in Asheville, except that I grew up in Durham, and I came back to take care of my mother, who was still living here at the time. And so we bought some property and built a house in Chapel Hill.
That's a beautiful place to live.
Okay, Wayne Jonas.
Okay, I think I learned how to get off the and the audio at the same time. Isn't that great? Great. Really looking forward to hearing your talk. I read your book. I heard you actually give your talk session you did a few weeks ago, and we've exchanged a little bit. I think we have a plan to talk in more detail after this. So I'm a family physician. I oversee, still in practice, but my day job is to oversee a foundation called the Samuel Foundation, which is interested in whole person integrative health. Wrote a book about that and look at advancing models of primary care that really take care of the whole person. We too look at goals, but a very different take. So I'm very interested I was very interested to learn how you do it, which I like a lot. And I've been trying to think about how it dovetails with us. We start with sort of the IHI model of asking what matters, the VA asking approach to what matters, letting the patient identify what their personal goals are, and then looking at trying to empower them to address the underlying determinants of health that will help get them to those goals. So have a whole system to try to train people in doing that. And I'll have to warn you a bit. You're very brave to come to this group. As Michael Fine will point out, we're revolutionaries here, and we're going to disrupt everything no matter what. And I was just on a call. We're sponsoring a session at the Society for Interdisciplinary Placebo Studies conference, which is in May. And the theme of the particular session is how the evidence underlying placebo effect basically invalidates most of what is called evidence-based medicine, because evidence-based medicine is driven by attempting to isolate effects that are separate from the ritual of care, and saying that those are legitimate, whereas the ritual is not by implication. And so we're gonna try to explicate that a little bit at the conference. So, so I'm very skeptical about evidence. I want to know whose evidence is always it. Anyway, I'll stop there. That's my introduction. I'm really looking forward to your talk.
I had read your book about a year ago, and I dog-eared most, so many pages that I might as well just have not bothered to do that. But I went back to look at the pages I dog-eared in preparation for this call and the one that we've scheduled. And it's really interesting that your Hope interview, you came up with essentially the same questions that I did. So I don't think we're on different pages at all. I think there may be some minor differences. I don't think they're major.
Yeah, I love to do that comparison side by side. Be wonderful. Thank you.
Cool. Len?
Thanks, Larry. Hi, Jim. Family physician for 25 years on the front lines in a medium to big medical group. And eventually, through a series of revelations and finally not banging my head against the wall every night, decided to go into policy and change in healthcare, and ended up on a bunch of boards, committees, and commissions. And about 5 years ago, started helping people who were forming a market-based solution to providing infrastructure for community-facing primary care in underserved communities, that they believed you could do it with raising private equity and really scale growth where investment was needed. And I ended up joining them full time. As of now, we have 19 facilities open. We're serving about 100,000 patients. And all of those facilities are in communities that had not seen a dollar of investment of any type, let alone primary care, for years. It's a combination of Medicare Advantage centers, very qualified health center, community health centers, PACE programs for the frail elderly, medical respite, transitional care housing, and hopefully, Wayne, we'll be able to build an integrative care center. I do have to say,
let's hope so.
yeah. Well, Wayne and I are conspiring to get that done also. I do have to say, Michael, there's one exception to the statement about you never saw a health executive take a call at 3 a.m. Good friend of ours who he was the CEO of Care America, health plan out here that had at its peak about 400,000 members. We used to go to dinner all the time. And one night at dinner, he showed up with a gigantic suitcase. And I said, you have to go to the airport or something? He said, no. He said, let me show you what's in the suitcase. And I'm going back into the 1990s. And he opens up the suitcase. And do you remember the computer printers in the old days that printed out those extra wide papers with the sprockets on either end?
There are little holes on it.
Like white and green,
Yep.
bars. That he had the printout of every single member of his health plan in the suitcase on paper. And I said, why do you have that? And he said, at his health plan, they make everybody in the leadership group take night call every day, every weekend, every holiday. because they are there to receive the calls when a patient has an emergency and doesn't know where they're required to go, who's contracted for their coverage, what's in network and not. So he was taking call. About 5 years later, he comes to dinner one night and the box is now not a suitcase, it's way smaller. And I said, what's in the box? He said, we got smart and we put it on microfiche. So he had literally had a little microfiche reader with all the members. About 5 years after that, he shows up with no box. And I said, where's the membership? Are you on call? He said, yes, I am. And he hands me his cell phone. He says, every patient's now in the smartphone. So they took call until that health plan met its demise, probably, oh man, probably in 2010 or so, I think it went away. But it got subsumed by Uni Health America.
Then I thought you were going to end up, I thought the story was going to end up, and so he became the CEO of United Healthcare. Because he was so committed to
Now,
that kind of work.
no, he actually now is, he runs the kind of health plan operation side of Kaiser.
Right.
Len, where do you live?
I live in Los Angeles.
That's what I thought, yeah. Do you know Lindy Knox?
Lindy Knox. Jay's shaking his head, but I can't remember what I had for breakfast today, but so.
You probably should, I probably should connect you with Lindy. She runs a practice-based research network, but they've been doing quality improvement work in lots of different practices in the LA area. And she's just a good person to get to know anyway.
Oh, I'd love to. I'd love it. Thank you.
Oh, Joe Grundy.
Sure. So Joe Grundy, I serve in a couple different roles. I am the executive director of the Direct Primary Care Alliance, which is the kind of organic physician association arm of the direct primary care movement on the national level. Also do a little bit of freelance consulting, helping health IT startup companies and other groups better understand primary care and how to help primary care physicians in the trenches. Like Jay, I came out of the AAFP for many years and then ended up working in the trenches before doing consulting work for one of the federal, the Beltway Bandits, working on CPC Plus, and realized that there really isn't much broad-based innovation in primary care, which is why I returned to my roots with the direct primary care movement. But nowadays, I mostly deal with happy primary care physicians, which is the norm, which is against the norm. But we are seeing more and more primary care docs and family docs specifically looking to direct primary care as an exemplar of what care could be, even if it's not necessarily for them per se.
Would you consider MDVIP direct primary care?
No, so MDVIP is almost a classic concierge model. So they still accept insurance, and then they charge. They're not allowed to call it an access fee, but it's an access fee on top of it. So it's just standard insurance, copay, deductibles, the whole 9 yards, and then the members pay for quote unquote uncovered services. Whereas direct primary care is in effect, it's a limited capitated model for comprehensive primary care services. So it's like a gym membership for primary care.
Yeah.
Okay, so Jim, why don't you take it away?
Okay. I only have a few slides, and you can stop me at any point, and we may not go through them. I think I have 9 or 10 slides. The 10th one is some cases, but I think I told you some things about this before, and you have the book, so we may not have to go through all this. But here's who I was. I was a family physician in private practice in a rural town. I did everything: OB and hospital work, nursing home, home care, everything. And then decided I was really an academician, and I went to the University of Oklahoma that's an interesting story. But anyway, I ended up at the University of Oklahoma and was there most of my career. When I got there, they needed a geriatrician, and so I taught myself geriatrics, and then did a mini fellowship and started building geriatric rotations for the residents and so forth. And then I decided I wanted to be a researcher, and they asked me to write a grant to establish a practice-based research network. And so I did that and spent the rest of my career, the last 15 years of my career, doing practice-based research, which started out as studies of common problems, but ended up studying how to help practices improve. And so I became an implementation researcher before they called it that. But all along the way, I was trying to figure out a way to make healthcare more humane. I'd had enough experiences in small town practices to understand how important it was to have a long-term relationship with patients, and to know them and their families and their context and so forth. And so when I was doing geriatric rehabilitation, I became aware of the idea of goals. And particularly, I was impressed with what the occupational therapists were doing. They're very goal-oriented. Basically, that's the one discipline that is significantly and expertly goal-oriented, but they only focus on current quality of life, basically. So it wouldn't be it's not a complete model, but it's an interesting model. So I started wondering, and I was working with educators also, PhD educators in the department. We're trying to design a mentorship program for the residents, and the educators were talking about goals as well. They were talking about individualized educational plans for students and so forth. So I started wondering, why is it that physicians don't focus on goals? Why do we always focus on problems? And you know, I've thought about that now for 30 years. And I still think we should focus on goals, and I'll explain to you why. And we're one of the only fields in existence that doesn't do that, actually, if you think about it. I mean, when you go to your financial advisor, the first thing they ask you is what are your financial goals? You know, educators use goals. Mental health folks are pretty much goal-oriented. Business is goal-oriented. You know, it's hard to think of a discipline that doesn't focus mostly on goals to start with. But since retirement, I'm a grandfather now, except my grandkids live in Australia, which is unfortunate, especially in a pandemic. I live in a neighborhood with a community garden, and I'm in charge of that. We have a dog and lots of trails. I try to play the banjo, mostly for myself. And I'm doing more reading than I ever have in my life. I'm also a consultant, even though I'm retired. I do consulting work for the University of Oklahoma and the University of North Carolina. And when I was still at Oklahoma, a fellow who I was working with, who I'd hired to work with me in geriatrics, I talked with him about goal-oriented care. He loved the idea. He knew how frustrated I was that I couldn't convince physicians to do it. And he told me, when you retire, write a book for patients, because patients might be able to convince their doctors to do it. So I wrote the book for patients. And then because I found that I was able to do that and I still had some life left, I wrote the book for doctors just in case. So it's a very simple idea. Remarkably difficult to explain to physicians, but everybody else gets it right away. That is, prior to consideration of possible strategies, clinicians and patients should clarify, either explicitly or implicitly, patient-relevant goals, priorities, and trade-offs that they can agree to. I mean, that's so obvious and simple, and yet it's not what we do. So the clarification step shifts the focus from problem solving to goal achievement. What we were taught to do is solve problems, and if we solve all the problems, that the goals will take care of themselves. So we took a shortcut, and we assumed that we wouldn't have to do the goal setting step. But when you do focus on goals, it forces you to think about, well, what are the goals of healthcare? And then that forces you to think about, what do we mean by health? And so that's been an interesting journey for me. When you focus on goals, when you focus on problems can be separated cognitively from the person that has them. I mean, you can have a conference on Parkinson's disease and never talk about a particular person that has Parkinson's disease, but goals are not separable from the patient. So, and patients have critical information that has to be taken into account during the decision-making process. So it elevates the role of patients in decision-making, and it broadens the range of potential strategies beyond problem solving. So if a person's goal is to be able to garden, there may be medical things that could be done to help them achieve that goal, but there may be a whole wide range of other things, even to the point of saying, well, is it really gardening that you want to do, or is it just being outdoors and working with your hands? And in which case, there are a variety of other strategies that might be appropriate. I remember one patient who wanted to have a dog, but for a variety of reasons he couldn't, mainly because his apartment manager wouldn't let him have a dog. But he was able to become a dog walker, and then he eventually became a dog trainer. So it also encourages individualization, obviously, and prioritization, which I think is critically important. And if we want to reduce the cost of care, I think you have two choices. You can either ration or you can prioritize. And we don't have any basis within a problem-oriented system for prioritization. When I asked residents to prioritize this person's problems, they always picked the problems that they could measure. So they always said, well, we should, hypertension obviously is the one we prioritize. But that's totally arbitrary and may not apply to that person at all. It supports teamwork. The one critical ingredient in teamwork is that everybody works off the same page. They understand what the goal of the operation is. And it creates a conceptual framework for person-centered care. I think that's what we lacked when the discipline, the specialty was created in 1969, and we decided we had to have a seat at the table in the medical center. And what we wanted to do was keep what was good about the GP, but add additional training in medical science. But we didn't have a conceptual framework that allowed us to do both. And so we pretty much adopted the framework that was in existence, which was the subspecialty framework. I think beyond just taking care of patients better, I think this could provide a blueprint for the transformation of practices and healthcare systems. I'm a co-author on a paper that talks about that. And I think it may be the best way to align primary care and public health. I had a lot of experience in Oklahoma trying to do that. And you're all aware of the cultural gap that exists between primary care and public health. I think that can be bridged through a goal-oriented approach. So I told you I had to reconsider my definition of health. And this is what I've come up with approximately. I worded it a little differently each time. So if life is a potentially magnificent journey filled with incredible challenges and opportunities and inevitably ending in death, then health is the ability to face the challenges and capitalize on the opportunities in order to garner maximum enjoyment, growth, meaning, and fulfillment from the experience. So if that's the definition of health, and I guess you might argue, you might be able to write that better, but I think in general that's what health. We probably could agree on approximately that definition. Then healthcare is care that's designed to help each person live as long as possible up to the point where they wouldn't want to be living. And everybody has a different point. And it's important to identify what that point is. Maximize quality of life, optimize personal growth and development, and experience a good death. Those are essentially the major goals that people have, whether they express them or not. And that's important because most patients focus on quality of life. And it's our responsibility to remind them that if you're not alive, quality doesn't make any difference. So I think it's an interesting, I don't know what you would call it, but an interesting a word for it, where the physician is emphasizing length of life and the patient's emphasizing quality of life, and you end up agreeing that both are important, and then you talk about trade-offs. I'm going to go through this one pretty quickly. So I only do this because when I talk about goal-oriented care, people start thinking about exercise goals and diet goals and those kinds of things. And because Wayne just mentioned he thought maybe our definition of goals was different. My definition is this: a goal is a desired outcome for which it makes little sense to ask so that or in order to. An objective is a measurable step along the path, and a strategy is a way to achieve an objective or a goal. So taking hydrochlorothiazide is a strategy that could reduce your risk of cardiovascular events in order to prevent avoidable death or disability, which is the goal. It doesn't make much sense to say, why would you want to prevent avoidable death or disability? That goes without saying. If you want to have a vegetable garden, you probably need to be able to kneel down and bend and reach and so forth, which is the objective. An occupational therapist might have some suggestions regarding flexibility and also some adaptive equipment, which would be strategies. But the goal is having a vegetable garden. And you could ask, so that, why we want a vegetable garden? In that case, if they answer the question, they're probably getting at the value behind that goal, but they're not changing. That is the goal. So a psychiatrist who studied with me in medical school has come up with this very nice little way of thinking about the process that he uses, and it's the process that fits goal-oriented care as well. So you connect first around what matters to patients. You then co-create a plan that makes sense for given their resources and preferences and priorities. And then you collaborate to make sure that that plan can be successful, basically. And then you make adjustments, and the adjustments are probably as important as the original plan. So you assume that you need to make adjustments, that you never get it right the first time. That's kind of the process. So regard to adjustment, traditional meanings of compliance and adherence are irrelevant because you assume that you won't get it right the first time. There's no blame attached. You just miscalculated, and so you go reevaluate and come up with a better plan. And sometimes you have to reevaluate whether that actually was the goal. So some cautions. It's a conceptual framework. It's not a technique or a set of techniques. And important for this group, it can very comfortably accommodate a wide variety of methodologic and therapeutic approaches. It's perfectly compatible with integrative medicine, functional medicine, narrative medicine, relationship-based medicine. You know, any one of a number of sort of methodologies could fit nicely within a goal-oriented framework. Since the 4 goals are known, I already told you what they are. It's not about goal setting exactly, although the quality of life goals have to be clarified. It's more about goal clarification than it really is about goal setting. There's no need for a goals list. And the process is at least as important as the outcome. Working towards something collaboratively is probably more important, I would say, than actually achieving it. It's the process that matters. I almost never use the word goal with patients. It's too big a word. And I was interested when you said, you asked them, how healthy do you want to be? I would have to first try to figure out what they mean by health. That's a big word, health. That's a complex word. Goal is the same way. I almost never use that word. But I do ask them, at what point would they not want me to treat pneumonia? Because I assume they want to stay alive. I assume they want to stay alive. That's an assumption. It's a goal. Everybody has that as a goal up to a point. So all you need to know is what's the point at which they wouldn't want that to be a goal. And we talk about hopes, and we talk about a typical day. Oh, hopes with regard to what would you hope to see during, what would you hope to live long enough to see happen? okay? And we talk about a typical day and what people can't do now and so forth. Problems are reframed as risk factors, obstacles, challenges, or opportunities. Best if they can be viewed as opportunities, but often they're obstacles or challenges. So these are some of the questions and concerns just to get our conversation started. First thing that physicians tell me when I explain this to them is, we already do this. And I would say, no, not really, not in any sort of consistent or organized way. If you have taken care of the same group of patients for 25 or 30 years, you may be doing this because you may be so invested in the outcomes of your patients that you actually have come around to thinking this way. It's possible, but you probably wouldn't be able to explain it. So I'm just trying to explain what you've learned how to do. But for most physicians, particularly younger physicians, they're not doing this at all. Second comment is, it takes more time. Not really, not so much actually. Once you have the processes in place, I did it. I mean, I didn't do it well because there are some obstacles like the electronic record and quality metrics and so forth. But it didn't. I mean, I was never real fast. Because I didn't think that, you know, a 10-minute visit was worth anything. But I don't think it takes longer than doing good care, good problem-oriented care, I should say. It's with regard to then they raise the question about quality indicators. Well, it's unclear to me whether the quality indicators would improve or get worse. I think some would improve and some would get worse for each patient. So for a particular person, it might make sense to lower A1C, and for another patient, it might not make any sense at all. But on the average, if you're looking across quality indicators, it probably would improve the quality indicators a little bit, just because people are a lot more likely to be adherent, if I can use that term, that they're more likely to follow the plan because they're invested in it, they've helped to design it. How will patients respond? The evidence suggests most love it, and that was my experience. I didn't have that much trouble explaining it to people. Once they understood it, they said, "Well, I thought that's what you did." I said, "No, that's not what most people do, but that's the way I do it." And then the question, what if patients' goals are unrealistic? Well, that kind of depends on the danger of disappointment and discouragement. Usually it's not a big issue. But if it's clear that they're going to be disappointed and that's going to be a problem, then you may want to, you know, negotiate some more. But doesn't happen often. What if the patient and physician goals are different? Well, that's unusual. I mean, I think sometimes the priorities might be different, but it's always the patient who wins that argument because they're the ones that it's their plan. So as long as you can agree. Now, if you agree, then they need to find a different physician. How will subspecialists react? I don't know. It's variable, depends on the subspecialist, but you certainly have to be better with your referral notes, be more specific about what you're asking for and why you're asking for it. Is there a danger of missing something important? Yes, that's a legitimate concern, but I think it can be solved by putting good processes in place. So I did a really careful annual evaluation, include a really good physical exam and review of all the risk factors and so forth. But I think you can do that with an annual big visit. Does it require a greater fund of knowledge? Yeah, it does. In fact, I don't know if I'm right about this, but I think one of the causes of burnout is that physicians are not working up to their level of competence. I think physicians are very smart people, and they want to take care of people, and they want to be creative and innovative and so forth. This cookbook stuff that they're doing now is not really satisfying. This does require a lot more knowledge of medicine and human interactions and every aspect of health. You need to know more about it to be able to do this well. There are a lot of disciplines besides occupational therapy that are actually doing some pieces of this. Palliative care is doing it. Sports medicine is very goal-oriented. PM&R to some degree, although I was a little bit disappointed in that. But mental health and behavioral medicine, social work, some areas of geriatrics, some people in oncology, some people in public health are thinking this way. There's pretty good evidence now from several different fields that this does result in improved care. You can just kind of skim that list. I'm not going to read it for you. If you're interested in this about increased life expectancy, that is an interesting topic. We could go into that if you want. It's in the book though. So I'll ask you, do you understand what I'm talking about enough to begin the conversation, or would a couple of cases help?
I think I understand enough, but I always love to hear cases. Okay,
well, I'll do it quickly. This is a 68-year-old man with oxygen-dependent COPD. He lives in an apartment by himself, having been widowed. He enjoys reading and television and some computer work. He has children and grandchildren that live in the area, and they come and visit often. He gets out of the apartment a couple of times a week to go eat at a local cafeteria. He's oxygen dependent. He's on some inhalers, and he's had all the immunizations that he was supposed to have. He's satisfied with his quality of life as it is. He wants to continue to live. He says that he would not want to be put on a respirator, but he would like to live as long as possible. He's enjoying the life that he has. The question, what kinds of things, if you were brainstorming with him about things that he could do to try to extend his life, to prevent premature death, what kinds of things come to mind? So when you talk to physicians about this case, all they can think about is COPD. That's the problem. He's got COPD. So how do we treat COPD? That's a problem-oriented approach. The goal-oriented approach says, how can we keep him alive? What's he most likely to die from? He's most likely to die from respiratory failure from an infection. I mean, he could have a COPD exacerbation, which isn't necessarily an infection, but I would say his greatest preventable risk factor are things that might cause infection. So, how can he reduce his risk of getting a pulmonary infection? He needs to not be exposed to people with contagious viral infections. So he needs I need to educate him, and he needs to educate his family. And we need to talk about hand washing, particularly when he's at the cafeteria, when he's touching all those utensils that a whole bunch of other people have touched. And if we want to try to reduce his risk of a bacterial infection of his lungs, those bacteria live around his teeth. And so he needs to have good oral hygiene. And we know that PPIs, possibly H2 blockers, increase the risk of pneumonia in people with COPD. So he needs to be told to avoid those now that they're over the counter. And this is getting a little bit speculative, but an ACE inhibitor might improve his cough reflex. He also probably should be taking multivitamin, I would think, just to be on the safe side. But there's no great evidence to support that. Right? So can you see the difference between trying to figure out what to do about his COPD and what to do to help him live longer? And that's the difference. That's the difference in It's not immediately obvious as I, just looking at slides, but when you see the case, I think it becomes clearer. So here's a 34-year-old woman with a chronic rotator cuff tear that she acquired when she was playing softball in high school. And she'd had trouble with it ever since then. She'd seen she'd seen several family physicians, she'd seen physical therapists, she'd seen an orthopedist who offered to do an operation, guaranteeing the result. And the recovery period is kind of rough. And she tried non-steroidals and ice and all the different exercises and so forth. So when she saw my colleague, Jeff Steinbauer, and we had been talking about coronary care, he said, well, what would you like to be able to do that you can't do now? How does this affect your life? And she said, well, I used to go bow hunting with my father and brothers, but now I can't pull the string of the bow back. I really miss that. And that's really the main thing that bothers me about this. And she said, but I think in Oklahoma, if you get a doctor's note, you can use a crossbow. And so he wrote the note. So again, everybody else was focused on the rotator cuff tear. How do we fix a rotator cuff? And certainly she deserves a normal shoulder. She's 34 years old. And I'm not saying she shouldn't have the operation, but the quality of life goal was to be able to go behind. Nobody had asked her those questions. So I'm going to stop there and see what questions you have.
So I can send the slide set out to everyone, Jim, so that they will have those in the supplementary slides as well.
Yeah, I'm trying to figure out how to get rid of them.
You have to stop screen sharing. Go down to the bottom and stop screen sharing. There you go.
There we go. Okay, got it.
Yeah, once I understood your goal, Jim.
That's the best I can do to explain it, except in the book. I mean, I think I did a better job in the book, but it took 100 and some pages or 200 and some pages. That's been one of my problems through the years, is trying to explain this to physicians. They just don't get it. Patients get it right away. The other thing I figured out, when I first thought about this, I thought it was a pretty simple idea. I didn't think there was anything complex about this. It's very obvious. But when I wrote the first paper, I wrote it with Lauren Becker. I don't know if you know Lauren Becker, and Greg Blake, who's now in Tennessee. And they said, well, this is just a paradigm shift. I said, no, it's just a simple idea. Well, turns out it is a paradigm shift, and that paradigm shifts are difficult to force.
Jim,
go ahead.
Jim, it's Jay Fetter. Quick question for you. I really liked your notion of not using the word goal. I've been teaching motivational interviewing for a few years now, going back to my transfer med days, but we do use and teach the concept of goals, and we use the word goals, and we talk about it with patients, and we teach it. And I wonder, and when I read that, I was trying to imagine how I would talk about goals and train other people to talk about goals without using the word goal. And I really had a hard time doing that. And so I feel like that could be an extra special course in and of itself. But I thank you for, putting it in my brain and making me kind of go, okay, I got to figure out how to do that, particularly with our care managers and other folks who are very, in dialogue all the time about goals.
Well, if you accept my 4 major goals, goal categories, if you want to call them that, each one is different. So the questions you ask are different for each of those. So for the quality of life goals, which are the ones that people mostly want to focus on, you basically ask, what's a typical day like for you? Mm-hmm. What kinds of trouble do you have during a typical day? What are the things that give you the most difficulty? What would you like to be able to do that you can't do now? What are the things that make life worthwhile for you? Now, a lot of those questions are in Wayne's book, but you don't have to ask what are your goals, because it becomes clear from those questions.
Yeah, thanks.
Put people on the spot and just ask for reactions, and maybe we can do a little jazz here and kind of play off one another's ideas. Michael, let me go to you first. Your reactions and thoughts?
Well, I had a funny thought, Jim, as you were talking. There's almost something about this goal process that reminds me of harm reduction in public health. That instead of, sort of getting focused on the perfect, we try to figure out how we can improve things for people. And I think the absence of harm reduction gets public health into trouble. We get fairly, I don't know, opaque in our messaging. And, we kind of come off like, if you don't do it our way, the world's going to collapse, which people quickly find out isn't true either. So there is some beauty to meeting people where they are, considerable beauty to meeting people where they are and listening. And I think that's, why don't I make this comment in memory of Bernie Lown, who died about 2 weeks ago, who kept bugging us all, mostly to listen.
As I say, the process is more important than the outcomes. If you can agree on the direction you're headed, it makes everything work better. I mean, because as you all know, the relationship is the most important ingredient, and if you can, in working together in a trusting relationship, you can make a lot of progress toward better health.
And just parenthetically, I also have been for many years interested in a definition of health. Some of us know I tried a book called The Nature of Health about, now 15 years ago. It came up with a similar but real, sort of not exactly the same definition, but a similar one. When we worked it through, it looked to us like health was the equal ability to function in the relationships that are important for a person's place in their culture and at their point in the life cycle. But I think the idea of contextualizing health, it doesn't exist as an absolute, but it's healthy for what? Healthy to achieve what? Healthy to accomplish what? Healthy toward what goal? And why be healthy? Those are kind of critical questions to think about as we think about both the health of individuals and the health of the public.
Yeah, and as I say, I was a geriatrician. All my patients, my average patient was 80 years old, and if you ask most doctors to plot health on a graph, it's a downward curve, basically. but that always seemed so depressing to me and to my patients, and so it certainly seems depressing to me now. But it doesn't have to be that way. It depends on your definition. If you define health the way I'm defining it, health could improve throughout life. It's more like a slope on the curve rather than a point. And that curve could be upward. I mean, you have basically, if you were going to measure it, which I don't suggest you do, but if you're going to, it's a vector in 4 planes.
And I'm going to turn to you. Any thoughts, reactions?
Is that me, Larry? I couldn't hear you.
Yes.
Yeah, thank you. I do have a few. As you were speaking, Jim, I was thinking back to so many years and so many patients about the trials and tribulations of trying to do the right thing and occasionally knowing what the right thing was as their doctor, guided by what they wanted and the goals they were trying to get, but running headfirst into a climate of a system we work in where everybody from my own medical group leadership to the health plan the patient belonged to the state I saw patients in, and to the federal oversight of some of the patients because of the program they were in, all reviewing the record of what I did with the patient. And sometimes there would be a request and goal from the patient that would not match whatever the authority was that was looking over my shoulder at what I was doing and whether it was right or wrong what I did. So documentation comes to mind about the struggle to adequately put in the record what I was doing and why. You know, the old joke comes to mind about how people misinterpret things you write down and say. The old joke of, I was having a discussion with my wife and we were talking about life and, you know, the way to kind of go through life. And I said to her, you need to embrace your failures. And she gave me a hug.
When I was working on this initially, a long time ago in the 90s, I ran across a paper by a fellow who was in Denver. He was a quality improvement or a quality assurance person in the hospital in Denver. He wrote a paper that must have been in a good journal. I saw it. He said basically he couldn't tell what the quality of the care was really because he didn't know what they were trying to accomplish. Nobody ever specified what the purpose of the activity was. So he couldn't tell whether they had chosen the correct activity because he didn't know what the goal was. So I agree with the documentation. You need to document why, but I don't think it's that difficult to do. It doesn't fit a SOAP note exactly, but more of a need the hope note.
So Pat, thoughts, reactions?
Yeah, I'm very stimulated by this, Jim. Thank you so much for joining us. It certainly overlaps with a lot of things we've talked about over the past, and I'm particularly interested to hear from Wayne and would love to be a fly on the wall when you and he go into this in more depth, because I think both of you have been approaching this. And as you said, it seems like such an obvious. I wonder, you know, when we got into healthcare, the revolution was the SOAP note. You could actually focus on problems. You could, you know, show, you know, it was a very logical approach to the different problems. And I remember learning that as a medical student and a resident, but wondering about all the things that don't fit into, you know, those types of problems. And my mentors would always say, well, the SOAP note is what you do to get paid. Everything else is what you do to help your patient. And I think we've struggled with that for 40 or 45 years now. And Joe, I think you might have the best insight into when you totally restructure the financial payment system, in a sense, being able to get away from the, you know, fee for service and EMR that basically was created and only exists to try to maximize billing from each interaction. As you said, Joe, you get to work with happy family doctors and happy primary care doctors. Does it strike you that this approach makes much more sense in a sort of a capitated system that most of your direct primary care physicians work in?
Absolutely. I think that this, so I mean, this is to a point that Dr. Mold made earlier, this is almost fundamental to the training that family physicians receive and their capabilities to engage with patients, and as a core tenet of kind of that je ne sais quoi of relationships, right? And that's the type of thing that, you know, earlier, a couple of you were joking about it, like what's the CPT code for compassion and caring? Like this lines up perfectly with a DPC-esque model, a comprehensive payment that isn't built on time, but necessarily built on access in terms of like having access to your physician. And so, I mean, like, you know, it also in direct primary care and other comprehensive advanced primary care models, like a physician can take the time to elicit the answers, like true human motivational goals rather than the quote unquote care goals as Dr. Mold laid out earlier. And I think that this is something that every primary care doctor probably has an intuitive want to do. It's just that they've been inculcated by fee-for-service to avoid doing, right? Because to your point, Dr. Tokas, like, they don't get paid to do it. In fact, they have every incentive to not do it in a fee-for-service regimen.
Well, it's more complicated than that. I think you can do this in a fee-for-service system. It's not just that the fee-for-service system has prevented us from doing it. There's the uncomfortable part of this is that physicians at some level like problem-oriented care because it allows us not to, it saves energy and it allows us not to get too close to people. And my experience is when you give doctors all the time that they want to see patients, they don't know what to do with it.
Yeah.
They don't know what to do with the time.
Well, so that actually is a really interesting point. Like so like every business model, there are successes and failures in direct primary care, right? And one of the factors that, you know, I don't have the data, this is purely anecdotal and personal perspective that I would lean into on this is those doctors who look at themselves as data scientists first rather than humanists first don't do as well in a direct primary care framework, right? Because that, to your point, and I've never had that nomenclature, they look at it as a clinical problem solving puzzle with each patient encounter versus someone who views themselves as a healer first looks at it as this kind of an encounter with another human being, and a human being is always more complicated than just a set of problems that need to be addressed, right? It is a comprehensive thing, or I should say a comprehensive person with all the aspects of personhood that tie into health and wellness, rather than just here are the clinical factors that I need to address and the data says this. And therefore, you know, I'm going to recommend this specific course of action for you, and it's a clinical regimen, and that you should be fine, right?
And that's what I was taught in residency by Gene Farley and Jack Froome and the other folks in Rochester at the time. But they didn't tell us how to do that. I mean, yeah, I've always been a humanist, and I've always appreciated the context and so forth. But tell me how to do that. I mean, what questions do you ask? When I went into practice, I started asking people, you know, tell me about yourself. Tell me as much as you can about yourself in 5 or 10 minutes. They didn't know how to answer that question. It was a stupid question.
Yeah, that's a good point.
Nobody taught me how to take care of a whole human being. I mean, it was aspirational. You know, we were talking about biopsychosocial model and so forth, but we didn't have a conceptual model for how to do that. It just made us uncomfortable, really.
Jim, I think that also brings up the point you made earlier that most of us, or many of us, at least in medicine, are feedback oriented in terms of whether it's grades or you know, getting the blood pressure down. In other words, we like to have tangible goals. We like to have things we can measure, and we like to be able to see progress in things that we're measuring. How does that translate to what you're doing with patients? Are you keeping track in your notes? Well, these are our goals, and here's how we're getting closer to these, and here's how we're not getting closer to these. And so do you develop your own system of metrics, if you will, in terms of to measure your success?
Yes, and I'll give you an example I just sort of mentioned in going through the slides. So we developed, for the prevention goal, for preventing premature death and disability, we developed an algorithm, a computer program that captures 215 risk factors in 13 different categories, including social determinants and diet and exercise and diseases and, you know, every family history and so forth. And it then attaches those to risk reduction strategies for which we have some evidence that they have some effect. And we use a proportionate hazards model so that the report that you get at the end of this is, these are the things that we know of that you could do to increase your life expectancy. And this is what your life expectancy is now. This is how much you can increase your life expectancy if you do all of these things on the list. And this is how much you get for each one of the things on the list in order. So if you were going to pick one thing that you might do to increase your life expectancy, it would be stop smoking. And that so far outweighs everything else on the list that really probably is where we should probably concentrate our effort. And so then you can measure estimated life expectancy on a periodic basis every year and look and see, are we making progress? So that's an example of what you're talking about. But with regard to quality of life, I mean, once you've decided that this person wants to be able to garden, have a vegetable garden, I mean, that's something you can track over time. And if I were going to design an electronic health record, it would have 4 sections, one for each of the goals, and you'd have a way of tracking progress toward each one of them.
And tell us a little more about how that approach with tracking these things, which are more, you know, patient developed goals, fits in with fee-for-service medicine, where you have to, you know, you have to have a specific diagnosis code for each visit, and you have to you know, check off these 47 different things that you did or didn't do in your EMR in order to get this quality of pay versus this quality of visit. How does that translate in what you're doing in fee-for-service?
It doesn't, but I don't think, I suspect that the most direct primary care docs are using the same EHR that I used. I mean, it's not, that doesn't solve the problem. You need a different record system. and you need different metrics, quality metrics. The quality metrics are a big problem, but the electronic record is the biggest problem.
Mm-hmm. Larry, I'm wondering if Rebecca's approach towards you know, measuring satisfaction of the patient, quality of the interaction wouldn't fit this model much better than the metrics that we're forced to use for Medicare and other insurance plans.
Well, I do think the disease-oriented metrics align with fixing the problems, addressing the problems, and not the person. So I think in that regard, it would. I do have to tell you, I was talking with an internist today by the name of John Wasson, if anybody happens to know John up at Dartmouth, and they've created a 5-question model that might actually align even better or together with Rebecca's beginning to think about. So he's just sent me some articles to read, and I'll get those out to the group after I've had a chance to read them. I'm looking at the time, and Wayne, I want to give you a chance to jump in here and see what thoughts and reactions you might have for Jim.
Yeah, thank you, Larry, and Jim, thank you for that talk. Thank you for your book. Thank you for changing the paradigm and providing some concrete ways to do it. I just love the process. It is a very different way of going about healthcare, but it is one that deals with the patient. It deals with the person, I'm sorry, and you use that term, person-centered care. And that's different than patient-centered care, which already is a medical framework, right? And I was very curious about and very interested in the goals clarification process, because my sense is that the goals clarification process that you say is probably the most important thing about this really is the anchor and is the center of all this effort. And so I was thinking again about, you know, how does this align with what what we do? And, you know, if I were to take that COPD case, for example, and I were to give him some of our personal health inventory, ask him to fill it out, and have him come in for, you know, an integrative health visit, doing a hope note, asking questions about all the dimensions of a human being, and our framework has 4 dimensions. The likelihood is that he would have, he may have said that I want to live a long life, if you'd ask him what was most important for him. But I would bet there's at least a 50% chance that he'd say, I want to spend more time with my grandkids. And those are a little bit in conflict, right? Because if he spends more time with his grandkids and doesn't do it in a safe way, he's more likely to get infected and die. And he may or may not be willing to do it in the way that we have. I mean, COVID is demonstrating how tired people are of not being able to spend maskless time with their grandkids. And Texas has just decided it's not worth it, right? And so, so there is this dance between what the evidence says, is going to help you optimize your function and healing, and what the patient wants. And it's really the process of developing that trusting relationship into which you can have a deep dive between what's needed and what's wanted.
Let me stop you at that point, because when I presented that case, I focused on length of life because I didn't want to drag it out. Okay, I was just focusing on that as an example of if you had a discussion with him about length of life. I didn't mean to say that that would be his first choice.
Yeah.
So I agree with you.
Understand. So goals clarification is the key process in this, right? You set out the goals in order to be able to work with the person to help them identify and track their goals. And that sometimes does require education about evidence. Yes, and bringing in the expertise that we have around what they want to have in life. And I think, that's what I was thinking about. And what we do is that's sort of the second step in what we do rather than the first step. We ask people what they want in life, okay, what's their meaning and purpose. And then we look at, well, how can they get there? And then we, kind of use the SMART goals framework and everything, which gets into the strategies. And how do you do the strategies? So I think they are very much aligned. We focused almost entirely on operational components. How do you do this? Because in my experience, once especially people that are in chronic disease management, primary care folks learn that there is this sort of different approach, different framing, they want to do it and they want to learn how to do it. And then it becomes a QI and an operational thing, right? I mean, how do you just fit it into the system? How do you get in the electronic medical record? How do you have the conversation? What your team need to do? All that kind of stuff. And so, that's really, to me, where I think if we were to provide more of that, I think there would be a growing interest, at least among the healthcare profession and patients, in saying, yeah, we want to do this, and hopefully maybe a demand for it, which I think what Michael's trying to create, that says, if you're not doing this, I'm not going to buy it anymore. I'm going to look somewhere else, right? In those areas. So it's really those kind of operational tools in that area. So those are just some of my thoughts around this. Is how do we make this easier to do, and easier to understand.
So there were a couple of things you mentioned that are really important. First of all, I remind you, I'm an implementation scientist, so I'm very much into figuring out how to make things actually happen. The other interesting thing you said was that the physician's knowledge is really important in the discussion. And there's some models out there now where they have someone else do the interview. So they have a facilitator collect all the information about goals and values and priorities and so forth, and then bring that back to the team. I don't think that works as well. I mean, it might work. It's not practical for one thing because there's no way to pay for it. But I don't think it works as well. But I think this is a challenging, a medically challenging activity, and you need to know a lot about what's possible and what's not possible in order to be able to have that discussion. So I agree with you in what you said there. but it does raise the question of how much time you want to take doing
Yeah.
this. And I never had more time than a usual physician did. I wasn't in direct primary care practice. So I kind of learned to do it maybe in a sort of a sloppy way. I mean, I didn't do the full HOPE interview that you do, but I think it was good enough. Maybe I was fooling myself. Maybe I just really didn't fully understand who this person was, but I don't know if it matters. I think that what matters is getting on the same page.
Yeah.
And working together on something, even if you're wrong the first time, because you're going to do it over and over again over a long period of time. Eventually, you'll get it right. I don't think you have to get it right up front.
Yeah. No, that's right. And this is where the continuity of care comes in a primary care relationship, right? Is that you can do this over a period of time, and it doesn't have to be done in a single visit. So anyway, I think, but you have to have that continuity of care in order to be able to do that. So.
No, I think, Jim, the reason I think having that other person collecting that data doesn't work is because it's about building a trusting relationship.
Yeah.
And having that's like a technician, and you're giving this info, the patient knows what's going on. You're just getting the information, and I'll take it into the doctor. Well, I want to engage with the doctor, and we're going to, work this through together. Now, I'm an unusual patient because I know too damn much, but I want that engagement to know whether or not this is the kind of person that I can really rely on and open up with. The other thought that I have, and I think it's something you didn't mention this evening, but in other conversations you've mentioned, you use the annual wellness visit. It is absolutely crazy, in my opinion, that Medicare created this annual visit, and you may not talk about any current problems. And so what a lot of practices and family physicians have done, they have the pharmacist go in and do the annual visit, or they have the whomever go in and do that so they can collect the nice fee and go over all of the stuff. But if you as the physician do that, what a wonderful opportunity, because you're getting paid for an extended visit, number one. And you have, even in the fee-for-service world, you have more time to engage around the goals that you're talking about. And then, when my experience, because I've been fairly healthy, is, if something comes up for me and I need to get a hold of my family physician, I get a hold of him and we deal with whatever that issue is that's come up. But I think to have the annual visit, and I think that annual visit could be done from, people at all stages, whether you're 20, 30, 40, 50. People die from drug, sex, and rock and roll in their younger years, and no one ever has that has an opportunity to provide the education and the intervention. So I think that annual visit has a lot of potential.
So my annual visit was a prevention visit. I wouldn't call it a wellness visit exactly. It was a prevention visit. It was focused entirely on the prevention goal and the end of life goal. So we also took care of advanced directives and so forth at that big visit. But prevention comes in all varieties. It comes in pre-primary, primary, secondary, and tertiary. So I also talked with them about their, what we would call medical diagnoses, medical problems, whatever you want to call them, that would be traditionally tertiary prevention. So the only registry I used was a preventive service registry, and it included their blood sugar and their blood pressure, and as well as their living situation and whether they've had immunizations and so forth, because all of those things, assuming there's something you can do with them to extend life, they all have to do with prevention. So, but that was a big visit, and I never charged for an annual wellness visit. I always charged a comprehensive visit.
Just a reminder about what my approach to CMS's crazy rules about all this stuff is. It's that we need to occupy CMS. It's another.
Yeah.
They've just come out with new sort of EMN coding abilities that really is trying to help people shift towards paying for time. Is that helping, or is it moving in this direction adequately, you think?
So Wayne, I'm not sure anybody on this call is seeing patients actively right now.
Okay.
You are, but you're in a military situation. So I don't know that applies.
Well, except our faculty just and Connie Earl on the faculty just did a recording about the new E&M codes and how you can utilize them that came out January 1st to really do more whole patient care. So so anyway, I just wondered about that.
My physician.
I'm going to bring things to close.
My physician does an annual wellness visit, and then he has me come back for a complete physical exam. So I have 2 big visits each year, which is fine. I don't mind. I think it's a good idea, but that's how he does it.
Yeah.
So I'm going to bring things to closure. Thank you, Jim, very much for what you're doing, and I'm excited to hear that you and Wayne are talking offline, so to speak. I personally think that your 2 models have a great deal of connection and synergy, and I think the more family medicine can come together to create a more robust mental model. Yep, there we are.
There we go.
Thanks, Larry, for bringing us together around this.
Yeah,
My
absolutely.
pleasure.
Yeah,
So
really
I
important.
There we go. How it really works. All right. So the other thing is, a month from now, Dave Chase will be on the call. He'll be talking about relocalizing healthcare and the Health Rosetta Project. Now we're kind of getting into system level things. So we go from more clinical to system level. And Jim, you're welcome to join with us. Please, anytime that you would like to do that. It's an eclectic group and in a whole, there's no method to the madness in terms of the topics, but I keep trying to feed things into the group that I think might stimulate some problem solving. This is all being recorded, and I will send to all the people who are in the group this recording as well as the slide set. So again, Jim, thank you very much.
And if anybody has any suggestions about where to take this next, how to get this actually out there in the world, please send them to me. I'm thinking in terms of some workshops maybe, or maybe bringing together people from different fields that are doing similar things, or I don't have a good clear path right now.
Yeah, let's talk about that. We'll talk about that, Jim. We'll do a webinar or something.
Yeah.
Okay.
Good night, everybody.
Great. Good night.
Thanks.
Good night. Thank you so much, Dr. Mold.
Thanks, Jim. Thanks, Larry.
My pleasure.